intact.
This patient was referred to me for endodontic treatment of tooth number 4. He'll have tooth number 5 extracted. But look at tooth number 4. Patient had all the signs of necrotic pulp with acute apical periodontitis. Let me show you different angulation PA. We never rely on just one angulation PA. This looks like a one rooted tooth here on this angulation. If you take another angulation, then you can see two roots, completely separate roots, and also you open up the tooth coronally here and you can see an overhang. So you can see a composite overhang here that's caused this widened periodontal ligament there. So when whoever did this filling for this patient left a huge subgingival overhang with that composite filling for this poor guy. Anyways, so take a look. We went ahead and did the root canal for him in one appointment. Let me show you another angulation. Again, you can see the composite overhang here, and you can see two completely separate canals or two completely separate roots. In this angulation, I want to show you this angulation. You can see the buccal canal here bifurcates apically, as you can see, bifurcates apically right there. All right. And this is another angulation, and you can see the two completely separate canals, two completely separate roots of this tooth. Everything went great. We went ahead and temporized the tooth and referred the patient back to his dentist. His dentist will prep the tooth for a crown, and I put that in the reports, that overhang on the mesial, composite overhang. While he's doing, the dentist is prepping the tooth, he'll remove that overhang as well. As I said, everything went great. We went ahead and temporized the tooth and referred the patient back to his dentist for the permanent restoration. This is another angulation of the tooth. This patient was referred to me for endodontic retreatment of possibly maybe tooth number 19 or endodontic treatment of tooth number 18. The story is, according to the patient claims about 2 weeks ago she went in and got a cleaning, and after the cleaning, tooth number 18 started to hurt. There was a lot of pain. She had to take pain medication for it. She contacted her dentist and was told that, oh, well, you just had your cleaning done, give things a couple of days. When in a couple of days, patient still had issues, problems, symptoms with this tooth. She couldn't even touch it, according to her. She couldn't even touch the tooth. There was that much pain. Tooth was very sensitive to chewing and biting on. She couldn't literally chew on the left side. She was seen finally by her dentist, and her dentist suspected that she grinds her teeth. And patient says, I don't grind. I've never ground my teeth. I don't grind my teeth, and that just doesn't make sense to me. Then the dentist says, perhaps maybe I can put some varnish. I don't know what that means. Varnish on your teeth, and maybe that'll help, and you can maybe start using Sensodyne toothpaste. Again, those are if there is perhaps maybe enamel loss and dentin exposure. Those are when patient complains. Maybe work if there is temperature sensitivity, but not if there is pain to chewing, to biting down on the tooth. Varnish, what would varnish do? So patient goes home again, but after the dentist put in a varnish, some kind of a varnish on her teeth, and patient still has the same issue, the same problem, pain to biting to chewing on the tooth. Finally, the general dentist, refers the patient to us for examination, possible endodontic treatment of tooth number 18 or endodontic retreatment of tooth number 19. number 19 root canal, according to the patient, was done over 10 years ago, and patient has never had any issues, any symptoms with it. Tooth number 18, when I saw the patient, percussion, very sensitive, palpation on the buccal side within normal limits. On the lingual side, there was pain to palpation. Tooth number 19, within normal limits to percussion, palpation, probings 1 to 2 millimeters. Tooth number 18, cold tested tooth number 18, within normal limits to cold. No cracks noted. Used a surgical operating microscope to confirm, and no cracks again noted, but what I saw was a lingual parulus on tooth number 18. So what had happened was that the dentist, when he had cleaned her teeth, he was perhaps maybe a little too aggressive with his cleaning instruments, and the gingiva on the lingual had been detached from tooth number 18. On the lingual side, the gingiva had been detached. So probing on the lingual side of tooth number 18 was 9 millimeters plus. Because again, of the gingival abscess, the gingiva had been completely detached from the tooth. So this was a classical case of a perio problem, perio abscess, perio problem, because of the detachment of the gingiva on the lingual side, creating a pseudo pocket, collecting food and microorganisms, and creating a gingival abscess. A root canal would not have helped this patient. So again, diagnosis is important. Going through every step, trying to eliminate what you suspect is important. And I told the patient, you don't need a root canal, just go see a periodontist. You want to see a classical case of coronal leakage causing the endodontic treatment to fail? This is the case. Take a look here. So this root canal, according to the patient, was done about 3 years ago. Recently, tooth started to hurt and throb. All right, so saw his dentist, and his dentist referred him to me for endodontic retreatment. I looked at the tooth, percussion tender, palpation tender, probings 2 to 3 millimeters, 4 millimeters in the distal. And as you can see, radiographs, previous root canal, and periapical lucency here. Let me show you clinically what we found. So as you can see here, this is all food. So the endo access that was made through the bridge there, that endo access after the root canal was done was never restored permanently. So patient lost the temporary filling, and of course now for the past 3 years food's been getting trapped. Food and bacteria, of course, saliva, bacteria. Take a look at this. That was the cotton pellet that I pulled out of the endo access that was right under all the food material, and you can see how how it looks. It doesn't look very sterile, very clean. All right, so that's a classical case of coronal leakage or micro leakage. All right, so you can see that's the definition of, so take a picture of this, please. Okay, so patient came back today, and we were able to redo the root canal for him. Of course, in one appointment, went through the previous endo access and removed the gutta percha and instrumented, shaped, irrigated copiously with 6% sodium hypochlorite, activated sonically, and obturated three-dimensionally. So take a look at the post-op. And here's the post-op. As you can see, everything went beautifully. We went ahead and temporized the tooth and referred the patient back to his dentist for the permanent restoration. And I could not emphasize more to the patient, please call your dentist right now and schedule an appointment. Don't let what happened to the tooth, that you didn't get it restored permanently right away after root canal, happen again. And patient promised that he would call his dentist right now to schedule.